I'm sorry, I can't put the slide up for you, but Fernanda Carvalho Poyraz is one of our neurocritical care faculty, an assistant professor in the department. She's going to be talking to us today about hemoglobin targets in acute brain injury. So thank you, Fernanda.
All right. I hope you can hear me okay. I'm going to switch gears a little bit here, but hopefully you guys will find this interesting and informative, and that will kind of raise some discussion points. I decided to talk about hemoglobin targets for patients with acute brain injury because in the past year, there were three big trials that were published on this topic specifically. So I think this is a good time to evaluate the results of those trials and discuss whether it makes sense to change management for our patients. To introduce this topic, I have an interest in anemia in brain oxygen delivery. And as you all know, the brain is highly metabolically active, consumes about 20% of the body's oxygen supply. And the oxygen delivered to the brain depends not only on cerebral blood flow, but also on the oxygen content in blood with it, which is determined by hemoglobin concentrations. And we know that anemia is very common in critically ill patients, and that includes patients with acute brain injury. And a number of studies have shown that reduced hemoglobin can impair oxygen transport to the brain, and that's both in preclinical studies and in patients who get invasive monitoring for measuring oxygenation in the brain. Historically, in critical care, there has been two general strategies for transfusing red blood cells, and one is the liberal strategy, and the other is the more restrictive strategy. In terms of the liberal strategy, that's focused on trying to optimize oxygen delivery to end organs. So the hemoglobin threshold there is a little bit higher, somewhere around 10 grams per deciliter, whereas in the restrictive strategy, a lower hemoglobin target is aimed for, something around 7 to 8. And the goal is to reduce transfusion-related complications that include thromboinflammation and immunosuppression. In critical care in general, there is one big trial that has guided guidelines and people refer to a lot, which is the TRICK trial, which I'm going to go over in a little bit more detail, but wanted to mention that it didn't show any mortality benefit of doing a liberal transfusion strategy, and therefore has kind of guided what we do today, which is targeting a hemoglobin greater than 7 for most general ICU patients. However, that trial didn't really include patients with brain injury. I mean, there was a very small minority of the patients included in that trial. So up until recently, there has been a knowledge gap about what is the appropriate transfusion goals for patients with acute brain injury. So I'm going to talk about three trials that came out recently: Hemotion, Sahara, and Train. And these three trials looked at this question in different types of neurological injury, and I think gives us a lot of new information about dealing with transfusion practices in the neuro ICU. So first, I want to talk about the TRICK trial, which is the older trial published in 1999, and this has guided guidelines for transfusion up until recently. It was a multi-center, randomized, controlled clinical trial in 22 ICUs in Canada. It's one important point about this trial is that at that time, red blood cell units were not leukoreduced. So they didn't go through a process that has become standard of care now, which is to filter out excess white blood cells that contaminate the packed red blood cells, and that is known for blood bankers and people who are interested in transfusions. Those white cells really contribute to the complications related to transfusions. So transfusions are much safer now than they used to be when the TRICK trial was conducted. And they compared restrictive versus liberal RBC transfusion strategies, enrolled a total of 838 patients who were critically ill. They excluded patients who were actively bleeding, who had chronic anemia, or who were undergoing cardiac surgery. The patients also had to have anemia, and that was defined as a hemoglobin less than 9 within 72 hours of admission to the ICU. And the two arms were restrictive, liberal, where restrictive was transfusing if hemoglobin dropped below 7, with a hemoglobin maintained around 7 to 9. In the liberal group, patients were transfused if hemoglobin dropped below 10, maintaining a hemoglobin goal of 10 to 12. The results of that trial are presented here, and I want to point out that about like 6% of patients or so, less than 10% of patients had neurological abnormality as the primary diagnosis. You can see that most of the common diagnoses were respiratory disease, cardiovascular disease, trauma. So not really a trial that included a lot of brain injured patients. The primary outcome of that trial was 30-day mortality. And there was actually no significant difference between groups, but numerically, there was a little bit of a lower mortality in the restrictive group, but the p-value was 0.11, so not significant. They did see a difference that was statistically significant in hospital mortality, with a lower hospital mortality of 22% versus 28% favoring the restrictive group. In addition to that, they also saw, as expected, lower red blood cell transfusion utilization in the restrictive group that received 54% fewer transfusions, and about a third of patients in the restrictive group didn't require any transfusions at all. And then in terms of complications, there were a number of transfusion-related complications that they looked at. And here, the safety profile of the liberal strategy was not as great. There was higher cardiac complications in the liberal group, including MI, pulmonary edema, and angina. And there was a trend towards more ARDS in the liberal group as well, although that was not statistically significant. And, I included here some of the data showing that there was this hospital mortality benefit, and then they also presented data that in some subgroups, there was a benefit of the restrictive group, even in their primary outcome of 30-day mortality, specifically in patients who were less severely critically ill with a lower Apache 2 scores. There was a survival benefit in the restrictive group and also in patients who were younger than 55 years old. So this trial, published in 1999, changed practice significantly. And in critical care in general, the consensus was that it's safe to do a restrictive transfusion strategy. This was overall using less resources, right? Because patients would require fewer transfusions. And there was a shift in practice for targeting hemoglobin, just maintaining it greater than 7, and significantly influenced guidelines. Now, this question about Luca reduction, I mentioned that the TRIC trial did not involve RBC units that were Luca reduced. Luca reduction became standard practice in North America and also in Europe in the early 2000s, and essentially involves a process where after red blood cells are collected, they go through a filtration process before long-term storage, where white blood cells are removed, and this greatly decreases the rates of transfusion-related reactions. Now this is completely standard. All the units that we give our patients currently are Luca reduced. And these are the current guidelines, which maybe are going to be updated with the trials that I'm going to talk to you later. But for now, the AABB is the association that people look at, like in terms of guidelines for transfusions, and they recommend transfusing if hemoglobin drops below 7 for most hemodynamically stable, critically ill patients. And there are no specific guidelines for specific populations like TBI patients, subarachnoid hemorrhage patients, or intracerebral patients. And they also fall into this general guidelines for for general ICU patients for transfusing if hemoglobin drops below 7. So let's now talk about some of the trials that came out recently. So the first one I want to mention is the Hemotion trial. So this was a trial looking at liberal versus restrictive transfusion strategy in patients with TBI, published in 2024. It was a multi-center randomized controlled trial in many countries, including Canada, France, Brazil, and the UK, in 34 different ICUs. And they enrolled a total of 742 patients with moderate to severe TBI. So these were sick patients. And the patients also had to have anemia in the ICU, which was defined as hemoglobin less than 10. They excluded patients who received transfusions before in the ICU as to not confound the picture. And their thresholds for the restrictive group was transfusing if hemoglobin dropped below 7. And for the liberal group was transfusing if hemoglobin dropped below 10. Very similar to the TRIC trial. But here, because we're in the post-Luca reduction era, all red blood cell units used in this trial were Luca reduced. So here are some of the results. Their primary outcome was unfavorable neurological outcomes at 6 months. Numerically, there was a lower rate of unfavorable neurological outcome in the liberal group compared to the restrictive group, but that was not statistically significant. Mortality ended up being very similar in both groups, about 26 or 20 to 27%. Numerically, there were better functional outcomes and quality of life trends in the liberal group, but none of these differences were significant. And I think the most concerning thing from that trial was that there was a significant difference between the rates of the incidence of ARDS with a little bit higher number in the liberal transfusion group compared to the restrictive group. These numbers were not that high, however. It was 3.3% versus 0.8%. In other infectious, another potentially transfusion-related complications, including venous thromboembolism and infections, were similar, very similar between groups, no differences. In terms of RBC utilization, the median number was 3 units per patient in the liberal group versus 0 units per patient in the restrictive group. And you can see here on the right a little bit of the baseline characteristics of these patients in terms of like motor GCS score, pupil reactivity. So these were moderate to severe TBI patients, and I would say we're not a TBI center, but these are fairly critically ill patients. Just so you have an idea of like which patient population we're looking at. And here, up here, you can see the actual hemoglobin concentrations for both groups. In the liberal strategy, they maintain hemoglobin around 10 versus something closer to 8 in the restrictive group. Some additional results here, but essentially it's what I mentioned. There was a numerical lower rate of unfavorable outcome in the liberal group, but none of these outcomes reached statistical significance. I want to show you to the extended Glasgow outcome scale score for both groups, the liberal strategy and the restrictive group. So I think visually it's nice to see the differences here. Mortality was pretty much almost exactly the same in both groups, and you can see a little bit more perhaps favorable outcomes in the liberal strategy group. So there was this numerical trend towards better outcomes in the liberal strategy group, but in the actual statistical analysis, they were not significantly different. So the conclusion for this trial is that it really did not support a liberal transfusion strategy for TBI patients specifically. So it really did not change practice. So for TBI patients, the transfusion target was still keeping hemoglobin greater than 7. And even though there were some trends and quality of life, numerically improved numbers in the liberal strategy, that wasn't really enough to change practice, especially in light of potentially a significant higher risk of ARDS in the patients who got transfused more liberally. Now, another very similar trial was conducted in a different population. This is subarachnoid hemorrhage patients, aneurysmal subarachnoid hemorrhage patients. So this also published in 2024. So this was the Sahara trial. It was a multi-center randomized controlled trial in 23 neuro ICUs in many different countries, including Canada, Australia, and the US. They enrolled a total of 742 patients with acute aneurysmal subarachnoid hemorrhage and anemia, defined as having a hemoglobin drop below 10. They excluded patients who were actively bleeding with hemodynamic instability, and that's similar to what other, like the TRIC trial did as well. And the transfusion thresholds were just like a bit different than the Hemotion trial. So the restrictive group got transfused if hemoglobin dropped below 8, and the liberal group got transfused if hemoglobin dropped below 10. And again, because these were more recent trials, all patients received leukoreduced red blood cells. And here are the results. Again, so the primary outcome was unfavorable neurological functional outcomes at 12 months. And again, you see numerically a lower rate of unfavorable outcomes in the liberal group, but this was not statistically significant. So this trial did not meet its primary outcome endpoint. There were no significant differences in functional independence and other quality of life measures. There was also very similar mortality rates, so similar to Hemotion, about 27% in both groups here. But one thing was different between both groups, and that favored the liberal strategy, which was the incidence of radiographic vasospasm, with a lower rate in the liberal strategy patients, 31% versus for about 41% in the restrictive strategy, and this was statistically significant. However, there was no difference in incidence of delayed cerebral ischemia or new infarction. In terms of red blood cell utilization, almost all the patients, 99.7%, received a transfusion in the liberal strategy group, and about a third received a transfusion in the restrictive group. Median number of RBCs transfused were 2 per patient in the liberal group and 0 per patient in the restrictive group. And the safety profile was pretty good for the liberal strategy. There were no differences in transfusion-related adverse events. And I put up here some of the numbers regarding the severity of subarachnoid hemorrhage. You can see the World Federation of Neurological Surgeons scale score about 3 in both groups here. In these patients, the majority of them required an EVD, for example. So there are patients that are similar to the ones that we take care of here at Sinai. So perhaps this trial, can apply. We can make inferences from this trial. Here is the hemoglobin concentrations that were achieved. Patients in the liberal strategy maintain hemoglobin around 11 over 21 days or so. And in the restrictive group, hemoglobin was kept around between 9 and 10, as you can see here. And if you look at the modified ranking scale outcomes, the liberal strategy group, there were similar mortality, as you can see here, but definitely a clear shift for more favorable outcomes in the liberal strategy group compared to the restrictive group. So, and this, some additional outcome results, which I have already summarized, but wanted to point out here that, and these are the actual numbers of lower incidence of radiographic vasospasm in patients in the liberal group compared to the patients in the restrictive group. So the conclusions from this trial is that a liberal strategy, at least in the subarachnoid hemorrhage patients, was not inferior to the restrictive strategy and may even reduce the incidence of radiographic vasospasm. So there is a clear signal for benefit, although the primary endpoints were not achieved. There's a signal for benefit without any evidence of harm in the liberal strategy. So it's reasonable to consider a higher hemoglobin target in these patients. And finally, I want to come to this last trial, which was the TRAIN trial. And this trial was actually positive and in favoring liberal strategy. So let's go over it. This trial was a little bit different because it did not look at a specific type of brain injury like the prior ones, but included patients with TBI, subarachnoid hemorrhage, and ICH. So it was a multi-center randomized controlled trial in 72 ICUs in 22 countries. They enrolled 850 patients with these 3 diseases and who also had anemia. And anemia here was defined as a hemoglobin less than 9. Excluded patients with active bleeding with hemodynamic instability. They also specifically excluded patients with recent cardiac arrest. The targets here for the restrictive group was transfusion if hemoglobin dropped below 7 for the restrictive group, and for the liberal group, transfuse if hemoglobin dropped below 9. And again, all patients received leukoreduced red blood cells. And here are the results. This trial actually met its primary endpoint of the rates of unfavorable neurological outcomes at 180 days were lower, significantly lower in the liberal group compared to the restrictive group. And you can see the actual numbers here, 62.6% versus 72.6%. They didn't actually see a difference in 28-day mortality. The absolute number was lower in the liberal group, but not statistically significant. Interestingly, and it makes sense based on the mechanism here, there was also a lower incidence of cerebral ischemia in the liberal group, with 8.8% of patients having cerebral ischemia versus 13.5%. And in terms of red blood cell transfusion utilization, about 90% of patients in the liberal group received a red blood cell transfusion versus about half of the patients in the restricted group. The median number of units utilized per group was 2 units per patient in the liberal group versus 0 units per patient in the restrictive group. And there were no significant differences in transfusion-related adverse events. So this was a positive trial, and you can see what hemoglobin concentrations were achieved in both groups. For the liberal strategy, hemoglobin was maintained almost 9 to 10 or so, and closer to 8 and to 9 in the restrictive group. And this is the outcome distributions here of the extended Glasgow Coma Scale scores, and you can see the shift. There was actually numerically less death in the liberal group, although not for mortality itself, there wasn't a statistical difference, but the overall favorable outcomes was significantly higher in the liberal strategy group compared to the restrictive strategy. And I wanted to point out which patients were included here. It was a mix of acutely brain injured patients. So TBI patients were the majority, 50 to 60% or so. There were about 20 to 25% of patients with subarachnoid hemorrhage and about 17 to 18% of patients with intracerebral hemorrhage. And these patients were sick. At randomization, the DCS score, median DCS score was around 6. And the vast majority of them, over 90%, required mechanical ventilation. So these are, acutely ill patients, very similar to the patients that we see in our ICU. This is the table with their main outcomes. I summarized most of these things, but again, wanted to point out that cerebral ischemia. So they looked at many adverse events, and there was no difference in the two groups in terms of adverse events, including transfusion-associated complications. And if anything, when they looked at cerebral ischemia, there was a favorable outcome in the liberal group with lower rates of cerebral ischemia. So this was very encouraging. And I also included here some of their subgroup analysis, because I think it's interesting to see whether the results are being driven perhaps by a disease type versus another. So when you break down by disease type, TBI, subarachnoid hemorrhage, and ICH, you see very similarly that there's like a similar trend. There's not a big difference in the relative risk here. And if anything, there was like a little bit of a more signal favoring a liberal strategy for ICH specifically. And remember that this is the first trial now that included ICH patients and looking at liberal versus restrictive red blood cell transfusion strategies. So in conclusion, this trial showed that perhaps maintaining a higher hemoglobin of greater than 9 grams per deciliter can be beneficial in patients with acute brain injury. It improved outcomes, and there was less brain ischemia, and it appears to be safe compared to a restrictive strategy. Now, we have to consider this trial in light of the other 2 trials too, the HEMOTION and SAHARA, because those 2 trials did not achieve their primary outcome. So I think some further meta-analysis may be needed to pull all the data that's available and help us interpret everything together. And I mentioned this before, but this was the only trial, the TRAIN trial, that included ICH patients. And so far, we don't have a trial specifically looking for ICH patients on whether they benefit from a liberal versus restrictive red blood cell transfusion strategy. Wanted to also mention that the results of the TRAIN trial go very much along with some of my own data, and this was work that got published recently in Neurocritical Care, where I looked at hemoglobin decrements in patients with ICH in 2 different cohorts and looked at its relationship with outcomes and cerebral ischemia as measured by DWI lesions remote from the hematoma itself. And we found that across the board in adjusted models, hemoglobin decrements significantly predict poor long-term outcomes, as well as the incidence of the presence of DWI lesions remote from the hematoma. So again, explaining perhaps going very much along with this idea that a higher hemoglobin could benefit patients through this mechanism of preventing cerebral ischemia. So in conclusion, I think I hopefully I convince you that the TRIC trial, which has guided practice for many years and is what a lot of the guidelines are currently based on, seems to be outdated because first, at least like as it applies to us, it didn't really include a lot of patients with acute brain injury. And at that time, red blood cells were not leukoreduced, so the safety profile of transfusions have much improved since that trial came out. And I'd say that overall in acute, based on these 3 trials that I talked to you about, the only evidence for harm with the liberal transfusion strategy was seen in the HEMOTION trial, and that was specifically in TBI patients regarding the risk of ARDS. But otherwise, a liberal strategy seemed very safe, and there was no evidence of harm in Sahara or TRAIN. So perhaps, there isn't this specific harm in subarachnoid hemorrhage patients and ICH patients. So I would say that it's reasonable to target a higher hemoglobin threshold, especially a target of greater than 9, which was what the TRAIN trial used, since there is a clear signal for benefits in subarachnoid hemorrhage patients and ICH, and no evidence for harm. And I hope I have convinced you of that, and I think this would be something that we consider in our patients in the neuro ICU. And I think these trials are going to guide future guidelines, and the guidelines could potentially change for what should be the transfusion targets in our patients. And let me know if you have any questions about this data, and I hope this can stir some discussion.
Thank you so
Thanks
much,
for the nice
Fernanda.
review, Fernanda. Fernanda, I wonder, one of the issues revolving, kind of including a broad range of patient subtypes, I think it kind of, muddies the interpretation a little bit for me. Do you know if there's any plan to focus on neurocritical care patients that are particularly at risk for ischemia? For example, the SAH population that experiences vasospasm, and then targeting, hemoglobin thresholds for that particular population, or the TBI population with elevated ICP. I think it would make more physiologic sense to target, hemoglobin thresholds higher in those subgroups of patients. But I wonder if what's sort of on the horizon and how you feel about that.
I'm not aware that there's a trial specifically looking at those patients. I think the best that we can do is look at, in the Sahara trial, the subgroup analysis, which they didn't explore so in depth in that paper, because but I think that data set, hopefully future papers come out kind of doing secondary analysis in the Sahara trial, to look at that patients who have vasospasm or maybe are a bit of a higher risk. But I still think that it really didn't cause harm, right? Like the liberal strategy, and there's a clear signal for benefit. So I think it may make sense to, even in all comers, with aneurysm subarachnoid hemorrhage, to maintain the hemoglobin a little bit higher, especially just higher than 9, for example. Is if you want to incorporate the TRAIN trial protocol into it.
This is a great talk. Thank you, Fernanda. It's good to see an update on these results, because I know we talk about these targets every few years, and it seems like everything's shifting on a regular basis. So thank you for presenting this. Does anyone else have any other questions or comments?
Fernanda, I just want to ask how you got interested in this. You said that there's a lot of attention now with these clinical trials. And I recall when you were still a fellow, basically, that this was your interest from way back. That's been kind of your mission ever since you came. So how did you get interested in this before the new interest came into it?
As a resident, even when I became interested in neurocritical care, one of my main mentors at Columbia has an interest in transfusion practices, and he looks at platelet transfusions. He had some data on anemia and ICH. So there are several hypotheses about how anemia leads to poor outcomes in ICH. One of them is that he has focused on is that it affects the ability of the clots to form, and there's more hematoma expansion. But everything that I have seen suggests that it might be this oxygen delivery capacity that matters. And so I have like some preliminary findings there where I saw this association. So I continue kind of to pursue this. And when I came to Sinai, I looked at the same question that I had looked at before in a different cohort, and it showed this association again. And it's exciting that these trials were ongoing, and I was looking out for the results of them in the past year, and they finally came out. So I mean, I think it started off because my mentor had an interest in transfusion, and I decided to kind of dive deeper into it.
Yeah, great. Well, along the theme that we were discussing this morning, it's important for you as residents to find this area that interests you, whatever it is, in any direction. And then to start delving more deeply into it and broadening your experience. This is how you make contributions. So thank you so much, Fernanda. Really appreciate it.
No problem. And yeah, I mean, I hopefully I convince some of you that in some cases it really makes sense to try to target a higher hemoglobin, but we'll see, how if the practice really changes, and let's watch out for new guidelines coming up soon.
Thank you.
All right, thank you, everyone. We'll see you next week in person in Hatch for the Malice lecture.
And breakfast before.